Hello.
This is Howard Goldman from Cleveland, Ohio. Happy to present our study on same-day discharge across female pelvic medicine and reconstructive surgery, whether it is safe and feasible, looking at a 10-year single surgeon experience. I wish we were in Melbourne, but hopefully we'll be together next year. We have no relevant disclosures, and at this point I'm going to turn it over to Dr. Jacqueline Zillioux, who was the lead investigator on this project.
Thank you, Dr. Goldman. Enhanced recovery after surgery protocols, the rise of minimally invasive techniques, and increased attention to value-based care have led us to reconsider routine postoperative admission for FPMRS cases. Recent studies have shown same-day discharge is safe and feasible for apical prolapse repair for a variety of approaches. We aim to assess trends in same-day discharge and associated 30-day outcomes across the FPMRS spectrum at our institution. To do so, we performed a retrospective review of all cases by a single FPMRS trained surgeon between June of 2010 and August of 2020. We queried the electronic medical record for patient demographics, length of stay, and 30-day outcomes, including readmissions and emergency department visits. We excluded non-FPMRS surgeries, such as stents performed on call, as well as cases where the hysterectomy portion was performed by a gynecologist, because in these instances, the gynecology team dictated discharge plan. To facilitate clinically meaningful comparisons based on same-day discharge, we created a subset of cases that were traditionally involving next-day discharge. Examples of these cases included robotic transabdominal apical prolapse repair, fascial slings, lower urinary tract reconstructive surgeries. We performed simple logistic regression modeling of the probability of same-day discharge and 30-day outcomes over time, and compared patient characteristics and 30-day outcomes based on same-day discharge status. We identified nearly 1,800 surgeries, including over 350 apical prolapse repairs, 370 slings, nearly 400 sacral neuromodulation cases, and nearly 250 genitourinary reconstructive cases. The vast majority of these cases, 79%, were discharged same day. We identified 601 patients in the traditionally admitted cohort and found that overall 30-day readmissions and emergency department visits were low and did not differ based on same-day discharge status. This figure demonstrates the logistic regression modeling of same-day discharge and 30-day readmission or ED visits over time in the cohort of patients who are traditionally admitted overnight between 2010 and 2020. As you can see in the top panel, same-day discharge increased over time from 32% in 2010 to 84% in 2020. Over the same time period, you'll see in the bottom panel that 30-day readmissions and emergency department visits remain stable. This table demonstrates 30-day outcomes based on same-day discharge status and the traditionally admitted cohort. As you can see, there were more phone encounters in the same-day discharge group, but we attributed this to the routine post-operative phone calls that our surgical team would make, specifically for patients who were discharged same day. However, there were no differences in emergency department visits or readmissions between the two groups, and patients presented at 5 to 6.5 days to the emergency department and between 10 and 11 days for readmission. The most common complication associated with these readmissions and emergency department visits was UTI, and there were few serious complications overall, with just 3 clavien dindo grade 3B or greater complications. Notably, none of the complications in the same-day discharge group would have been prevented by routine postoperative admission. We thus conclude that same-day discharge is safe and feasible across a wide breadth of FPMRS cases, with no associated increase in 30-day readmission or emergency department visits. These are our references. Thank you for your attention.